Good evening, everyone. Welcome to the fourth day of today's session. Today, we're going to be focusing on use of spectacles for management of myopia. As always, we're grateful to our sponsors, BioLens. BioLens are custom soft contact lens, custom contact lens company that manufactures custom contact lenses like scleral lenses, autokeratology for myopia management. As I've said in the previous days, stay tuned. During this week, BioLens would have a big announcement that would help practitioners who are interested in incorporating autokeratology undergo the training for it and become certified autokeratology fitters. So we'll dive right into today's lecture. I'm Obi-Wan Chukwuemeka Jr., and I'll be handling today's lecture. Over the past few days, we've talked about what myopia is. We've looked at the classification. We've looked at what the International Myopia Institute recommends for myopia management. And we've also looked at the definitions for high myopia versus the definition for pathologic myopia. Now, today's session, we're going to go right into the heart of myopia management and focus on ways we can prevent myopia progression or halt myopia progression in children as well as young adults as well. We know that myopia is defined as a condition where you have parallel rays focused in front of the retina when accommodation is relaxed. The International Myopia Institute defines myopia as a spherical equivalent refraction of above minus 0.50, and high myopia when it's more than -6, and pathologic myopia when you have an axial length above 26 millimeters, in addition to posterior segment pathological changes. We know that, so this was taken from the Global Myopia Awareness Coalition new toolkit for practitioners. And we know that the risk of having myopia can be divided into genetics versus the environmental part. For the genetics part, we know that parental history of myopia is very important. We know if one parent is myopic, there's a 2 times risk one of the children will have myopia. Both myopic, 5 times risk. We know that individuals from the southern part of Asia, also those who are from the Caribbean part of the world, tend to have myopia compared to others. We know that when the individual spends more than the required amount of time on digital devices, typically more than 2.5 hours, there's a risk myopia will develop. And children who spend less than 1.5 hours outdoors, there's a risk that they will develop myopia. Now, if you were to look at myopia management and divide it into the current options available, we have the spectacle options, we have the contact lens options, we have the environmental modifications, and pharmacological options. We will discuss each of these options over the course of the next few days, but today we'll be focusing on the spectacle option side of things. Now, before you dive into myopia management, you first would have established a risk profile for the patient you're trying to manage. You want to look at, from the genetics part, is there parental history of myopia? If yes, how many parents have myopia? Is it both or one parent that has myopia? Also, you might also want to look at risk of or history of complications in those who already have myopia in the family. For example, if there is a parental history of myopia, does that parent also have glaucoma? Is there have they had retinal detachments or macular holes or things like that? Because that also sometimes has a genetic predisposition, even cataract as well. Now, aside from the genetic side of things, or looking at parental history, you want to see screen time, outdoor time, digital device use, time they spend on near work, what distance are they spending on that? Are they keeping that near target or objects they are looking at? Because a child who has parental history of myopia, early onset of myopia from an age before 7, family history of myopia-associated complications like glaucoma, cataracts, or retinal detachments, or myopic maculopathy. A child who spends limited time outdoors, more time on digital devices, that's a very high risk of progression profile. Compared to a child who doesn't have a family history of myopia, maybe spends more time on digital devices and less time outdoors, and the other risk factors don't check out. So you want to create a risk profile and establish how fast the myopia is progressing to determine how you should intervene in that myopia management. Excuse me. Now, once you've taken proper history and you've established a risk profile and you know if this child is at high risk of progressing, low risk of progressing, or moderate risk of progressing, the next step you would go about is collecting your objective clinical data. Refraction, as we've said several times on this platform, we focus on cycloplegic refraction simply because we do not want to overcorrect and we do not want to undercorrect. Whether there is anisometropia or not, we do not want to undercorrect any eye. So if you have a patient who is maybe -10 in one eye and a -1 in the other eye, the old conventional way of doing things will be to give a -1 full correction and then maybe half the other correction so you can balance it and encourage binocularity. The problem with doing that is we know that when you undercorrect, you're going to induce myopia. So no, we don't want to do any undercorrection when it comes to myopia management. So we focus on full cycloplegic refraction so we get the full refraction data for that child. Now, one clinical advice I would give is be consistent with the cycloplegic agent you're using. If you're going to use tropicamide, continue that way when you're going to do follow-up. If you're going to use cyclopentolate, continue that way. Just to mention, if you have questions or contributions, leave them in the chat section and would take the answer, would answer those as at the end of the presentation. So be consistent with the cycloplegic agent that you use because that way you do not have variation coming in your results due to different tonic allowance from different agents. Sometimes it may be important to use atropine 1% to even do the refraction, especially in very, very young kids who have very stubborn accommodation that's all over the place. But you need to remember to remove your tonic allowance depending on the agent you're using. Typically, if you're using atropine, you're going to remove your 1 diopter tonic allowance. If you're using tropicamide, it's 0.25. If you're using cyclopentolate, it's 0.5. But you need to remember to be consistent with the cycloplegic agent you're using and ensure that you account for tonic allowance at the end of the day. Now, keratometry and corneal topography is advised when you're doing myopia control. Corneal topography is not compulsory, it is advised. If you're going to do orthokeratology, and if you're going to rule out secondary myopia like keratoconus or other forms of corneal ectasia, you would need a corneal topographer. So if you have a patient, say, -5 with -4 cylinder, you want to wonder where that -4 cylinder is coming from. Are you managing a patient with keratoconus as a myopic patient, or is this true keratoconus that you're seeing? And only a corneal topographer will give you that advice. A keratometer rather, can give you an idea, but keep in mind the limitations of keratometry. It's only going to give you an idea of the corneal curvature in the central 3 millimeter zone. Meanwhile, the standard corneal topographers will extend to about 9 millimeters or even about 11 millimeters, depending on the brand and whether you're using a corneal topographer or a corneal tomographer. A slit lamp examination of the anterior segment is important, obviously, to rule out pathologies on the ocular surface, rule out keratoconus as well. But a dilated stereoscopic fundus examination is extremely important when it comes to myopia management. Now, in as much as you can pick up your glaucoma or myopic maculopathy using your direct ophthalmoscope, which will give you only a monocular view, issues such as lattice degeneration, retinal tears, lacquer cracks, a lot of times these things begin in the periphery, not even in the central part of the retina. So it's important that you're able to see the central part of the retina or the posterior pole as well as the periphery of the retina. It's also important you're having stereoscopic view of the optic nerve head, especially because these individuals may present with glaucomatous changes, or something we call, that the International Myopia Institute has termed, high myopia associated glaucoma-like optic neuropathy. So sometimes you would see, I mean, it's a mouthful, but sometimes you see patients who have myopia, and you have diagnosed this person has myopia. You've decided to put them on an intervention, but the disc looks suspicious. You're not sure whether this is glaucoma or not. You do an OCT, it doesn't even answer the question. You do visual fields, you do your central corneal thickness, it doesn't answer the question. What studies have shown is doing a macular ganglion cell test as part of your OCT scan will help you distinguish whether this is optic neuropathy due to high myopia or it's true glaucoma. But again, that's not the focus of today's presentation, but just points to the fact why you need to have a stereoscopic view of the optic disc, so you can pick up things like peripapillary atrophy, tilting of the optic disc, because sometimes if the optic disc is tilted, your OCT is not going to compensate for that tilting. It's going to still tell you what looks superior to it is superior, what looks inferior to it is inferior. However, you are the one who knows that the disc is tilted and will have to reinterpret the OCT based on what you're seeing. Biometry is extremely important when it comes to myopia management. We prefer the optical biometer simply because it gives more repeatable results and it's more children friendly. But that doesn't mean that if you have an ultrasound biometer, you cannot use it for myopia control. If you also do not have a biometer, it does not mean you cannot do myopia control. What that means is you can refer to a center or a colleague who has the equipment, get the biometric values done, get the axial length data for that child or individual, and incorporate that into your myopia management profile. Managing myopia without having data for axial length is just like managing glaucoma without knowing what the retinal nerve fiber layer thickness is or what the macular ganglion cell thickness is. Yes, you can make the diagnosis. By looking at the optic nerve head, you can tell, okay, this disc looks glaucomatous. It doesn't follow the Asian rule. I may be seeing bayoneting of the vessels. The laminar dots look more obvious. Some part of the disc maybe looks, maybe pallor of the disc. You might pick up a retinal nerve fiber layer defect using your red-free illumination. You maybe have central corneal thickness, maybe the pressure is high, maybe there are some visual field defects, but you actually haven't measured the exact RNFL thickness in different locations of the optic disc. You haven't measured the thickness of the macular ganglion cells. So you're missing a huge picture of what you're trying to control or manage when you're looking at in terms of glaucoma. Because if you're looking at glaucoma, you'll be thinking, okay, you want to decrease the pressures, you want to prevent further RNFL damage. In myopia, we think of it as the same thing. Yes, you're looking at the numbers. Maybe the individual or the child is -1, -2, -3. But the interventions that you're trying to use at the end of the day is all targeted at preventing the axial length from increasing. So if you're only measuring the power of the eyes, you're missing a big picture of things. And we know that from studies done in Africa, at least in Nigerian school-age children, we've seen that changes in your axial length, very minute changes of about 1 diopter, will correspond to about 2.8 diopters, about axial length change of about 1 millimeter, rather, not 1 diopter, will correspond to about 2.8 diopters of myopia change. So what that means is, again, studies done in Caucasians show that that value is about 1 millimeter to 3 diopters. So what that means is if I have a patient who has an axial length of 24 millimeters, for example, and I see the patient in a year's time and that 24 millimeters has become 26 millimeters, I'm expecting approximately between -2.5 to -3 diopter progression in myopia. Now, very subtle changes in axial length matter. And clinically, we'll consider a change of more than 0.2 mm as clinically significant. Axial length has its physiological growth. Now, this is important because we're going to be discussing myopia management options or spectacle options today and looking at the efficacy. Now, a lot of times as practitioners, we get carried away with this would give 50% myopia control, this will give 30% myopia control, this will give 70, whatever percent myopia control. But look at the exact value, how much protection or how much reduction or how much prevention in axial length increase are you getting compared to control? That's always what should be on your mind. Forget about the percentages because sometimes those are misleading. But you need to realize that axial length has a physiologic growth. Although in Africans, currently, we do not have axial length growth data for children. So we are all using data for Asian or Caucasian or European eyes or what have you. But we don't have concrete axial length data for African school-aged children to look at how that progression happens without intervening in terms of myopia management, just the natural way the axial length increases. But what we know from data published from other ethnicities is we expect the physiological axial length growth to be about 0.2 millimeters per year. And that typically plateaus around when the child is approaching the late part of the teenage years. But what you want to do is when you map out the cyclorefraction of that child, you've mapped out the axial length of the child, you want to review that once every 6 months and see if that child is following the normal physiologic curve or if the strategy you've put in place, it's not strong enough to keep the child at an axial length growth of 0.2 millimeters or less per year. OCTs are extremely important, but it's not compulsory. I'm lucky to be in a practice where we have one, and also because I'm involved in myopia research. So we look at choroidal data and retinal thickness as it changes in different degrees of myopia. And the study that we had worked on that got published last year had actually shown that as axial length increases, the subfoveal choroidal thickness reduces. So for every, say, 1 diopter of myopia, that would increase or progress, the subfoveal choroid would thin about 15 microns from what we noticed in Nigerian school-age children. And also the retinal thickness also changes as well. Now, these can serve as early biomarkers for you to identify early signs of degenerative changes before they begin to manifest. Also, binocular vision tests such as measuring dysphoria or diplopia, looking at stereo acuity, especially when the individual has anisometropia, and then looking at accommodative response, that's doing your dynamic retinoscopy to get an idea of what the lag or the lead is if it's present. Now, there are some automated devices that can do this for you. For example, the open wide field automated refractor can actually check accommodative response for you. But again, if you don't have such fancy equipment, you can still measure your accommodative response using dynamic retinoscopy. And you can also use your normal von Graph or whatever method you would prefer to use for phoria or tropia to detect ocular deviation. And then stereo acuity. Now, stereo acuity is something that we often take for granted clinically, but it's very important, especially for children. And the reason why the binocular vision aspect of things is important when it comes to myopia management is because some of the interventions actually impact binocular vision, and sometimes the binocular vision status of the eyes may even detect the efficacy of whatever myopia management strategy you're going to use, and we're going to discuss this. So you don't have to be a jack of all trades. If you're like me and you're just specialized in corneal contact lens and myopia management, it's okay to co-manage with somebody who specializes in vision therapy. It's okay to co-manage with an ophthalmologist so that the patient is getting a holistic management. Also, when those degenerative changes like myopic maculopathy or Lacroix cracks have set in and has caused severe visual impairment, it's very important to also manage with people specialized, the practitioners specialized in low vision and rehabilitation, so that you are not just doing a one-sided thing where somebody's only getting management just for myopia alone. You're also managing the patient, not just the pair of eyes in front of you, and that's very important. Now, for us to actually dive into spectacle options for myopia management, which is the goal of today's discussion, we need to understand peripheral hyperopic defocus. Now, Generally, I mean, if you've ever dived into myopia management or thought about it sometime, you would have heard this term, peripheral hyperopic defocus or relative peripheral hyperopia. Basically, what it means is traditionally we give single vision spectacles or contact lenses to individuals who have myopia. The idea is we move the focus from in front of the vitreous to the retina. The vision is clear because now the image is at the foveal point and then the patient sees clearly. But the retina is not a flat surface, it is curved. So what that means is while we may have moved the plane to the central part of the retina and the vision is clear, in the periphery, the image focus is now behind the retina. And that distance between the peripheral retina and where you have the image focus behind the retina relative to the center is what we call relative peripheral hyperopic defocus. We call it hyperopic defocus because the focus is now behind the retina. And this image just illustrates that. We give single vision spectacles or contact lenses, image is on the fovea, vision is clear. And what do? We tell the patient, okay, go home, we'll see you maybe in 6 months or 1 year. Patient comes back. Because of that peripheral hyperopic defocus, the brain tells the axial lens there is a blur, or tells the eyeball rather, there's a blur at the periphery of the retina. Move the peripheral retina backwards to correct that blur. When the peripheral retina moves backwards, the axial length increases. And the patient comes back, we do the same thing. Single vision lenses, we induce clear vision at the center because now the image is at the fovea. And in the periphery, hyperopic defocus, the brain again stimulates axial length growth in the periphery. The entire eyeball moves backwards, axial length increases. And that's the idea behind why peripheral hyperopic defocus in a myopic eye will induce continuous axial elongation. Now, the idea of peripheral hyperopic defocus is still evolving. The initial idea was planted by Professor L. Smith, and this was many, many years ago. And based on this idea I have just explained is what most myopia control interventions, both contact lenses and spectacle options are designed based on. Most of them. There are a few options which we'll also look at that are not based on this theory, but most of them, about 90% of them, are based on this theory. Now, the idea of peripheral hyperopic defocus is not 100% explanatory for myopia progression. We know that even from the nasal to the temporal retina, there are variations. My research group presented a paper in academy last year where we are still, the study is still ongoing, where we are mapping out the peripheral refraction for African school-age children and young adults. And we're seeing that yes, in myopes, we're seeing more peripheral hyperopic defocus compared to hyperopes, but we're also noting that there is a difference between the magnitude of the peripheral hyperopia on the nasal retina versus the temporal retina. And by looking at from preliminary results we had presented compared to other ethnicities, we're actually seeing that the magnitude of peripheral hyperopic defocus varies from what we're seeing in the eyes of Indians, Caucasians, or Asians, which again boils down to the fact that we need to do more studies here so we can test out these devices to know whether they actually work for us or not. But again, we're hoping to conclude data collection very soon. So we should have that paper published pretty soon and hopefully out for readership late this year or maybe next year. But what we actually want is instead of doing the traditional method of myopia correction, where you're giving single vision lenses, which focuses images on the fovea, and in the periphery, you have hyperopic defocus. We want to actually correct that peripheral hyperopic defocus while giving central clear images, which is what the ideal thing should be, which is this. Now, based on that, we'll dive into the different options for spectacle options for myopia management. I'd just like to point out again, and I've said this before, giving single vision spectacles or single vision contact lenses is not myopia management. What you're doing is giving myopia correction. You're improving vision. It's just the same way as saying that if a patient undergoes LASIK or PRK or SMILE, you're controlling the myopia. No, you're not. You're correcting the myopia. They have clear vision. but you're not preventing it from elongating. And this is why in refractive surgery, we would usually advise that there has been no myopia progression for at least 1 year, and the child or the individual rather is above at least 18 years before you can recommend refractive surgery. In fact, most refractive surgeons will recommend about 21, 22 before they would agree to perform refractive surgery on an individual. Now, for the spectacle options, we're going to go from the least effective to the most effective. On the lowest side of the spectrum is progressive addition lenses. Now, there are studies that have actually looked at progressive addition lenses and bifocals in terms of how they control myopia. What, in terms of percentages, what you would see is between 13% to about 30% in terms of myopia control. However, you need to take this into context in terms of how much axial length control you're getting versus the control group. Now, this study was published in 2010. So this tells you that the idea for using bifocal lenses and progressive addition lenses for myopia control has been there for 15 years. And it shows that for those of us who are still saying you don't have access to the fancy myopia control lenses, we all prescribe bifocals. We all prescribe progressive addition lenses. These things have been published in literature, and it's been there for about 15 years. Yet, we still would say we're not, I mean, from the survey that we presented that was published in 2023, it showed that about 60% of African eye care practitioners are still prescribing single vision lenses, whereas data has been there for 15 years that has shown that at the lower end of the spectrum, you can prescribe progressive addition lenses or bifocals. Now, after a 3-year study, because what the IMI recommends is, yes, you can do your 1-year study to show efficacy, but to show true myopia control, we want to see 3-year data. So most clinical devices tend to publish 1-year data and then 3-year data, which is what we're going to be looking at. But we'll focus more on the 3-year data for studies that are for groups or devices that have published such. Now, we see that in this study that was published in 2010 by Desmond et al., they had looked at bifocals on one group. The addition was 2, and then they had looked at single vision in another group. And in another group, there was prismatic bifocals, which we'll talk about later. But what had been shown here is in the single vision group, the myopia progressed by about 2 diopters approximately after 3 years. In the bifocal group, myopia progressed by about minus 1.25 diopters after 3 years. And in the prismatic bifocals group, myopia progressed by about 1 diopter in 3 years. Now, is this 100% myopia control? No, because you still see myopia progressing a bit in the bifocal group and a bit in the prismatic bifocal group. However, if you compare that to the control group, you see that it's about almost half of it. Now, if you look at the axial length change, you would see that there's a progression in axial length of about 0.82 millimeters in the single vision group, about 0.57 diopters, millimeters rather, in the bifocal group, and about 0.54 in the prismatic bifocal group. What that means is over a 3-year period, the myopia progression was reduced by about 0.81 diopters in terms of looking at just the spherical equivalent refraction alone in the bifocal group, and in the prismatic bifocal group by about 1.05 diopters. So prismatic bifocals tend to be more efficacious. By the way, we're referring to 3 prism bays incorporated into the addition portion, and we'll talk about why that was done later. But these values here, because there is still about minus 1.25 diopter in the bifocal group and about minus 1 diopter in the prismatic bifocal group, when they were looked at a longer period of time, the efficacy starts to reduce. So that's why in terms of efficacy, progressive addition lenses and bifocals are at the bottom, maybe about 30% approximately. But it is better than giving your single vision lenses. And yeah, when the groups were studied in a longer period and looked at versus other devices, you tend to see that bifocals or progressives, they don't really tend to work except you're looking at several parameters. Now, these parameters are when you have a patient with, excuse me, let me see if that's somewhere here. Okay. All right. So when you have a patient who has a high lag of accommodation and near isophoria, bifocals give good myopia control. When you have a patient with near exophoria and a low lag of accommodation, bifocals or progressives don't really work very well. However, in those ones or those subjects or individuals or patients who have low lag of accommodation and near exophoria, incorporating 3-prism basing into the bifocal prescription actually boosts up the myopia control. So what this means is we can divide our patients into 2 groups. Low lag of accommodation and near exo will benefit from prismatic bifocals. High lag of accommodation and near ISO will benefit from your standard bifocals with an add of 2 or progressive addition lens with an add of 2. Now, sometimes clinicians want to tailor the addition that's given to a patient based on the accommodative lag. And to do this, what the normal accommodative lag is plus 0.5 to plus 0.75. So if you have an individual or a child or a patient with a very high lag of accommodation, say plus 2.5 lag of accommodation, removing 0.5 diopters from that lag of accommodation will give you the addition that you're going to give. So let's say I have a patient who is a -3, has near isophoria, has a high lag of accommodation of plus 2.5. Removing 0.5 from that plus 2.5 accommodative lag will give me an addition of 2 diopters. So I will be prescribing a -3 addition 2 for myopia control. On the reverse side, if that individual has a low lag of accommodation and near exophoria, I will be prescribing an addition of 2 with 3-prism basing incorporated into both eyes. And you can tell your lab to do this and they'll do that for you. Again, this brings you back to the point I was trying to make about binocular vision being very important when it comes to myopia management. Now, let's look at other defocus spectacle options. First, the very first defocus spectacle option that came out for myopia control, excuse me. This was the DIMS lens. So DIMS stands for defocus incorporated multiple segments. Excuse me, someone's mic is on. Please, everyone, mute your mic. Thank you. All right. So the DIMS stands for the defocus incorporated multiple segment. Now, this lens was designed over 6 years ago, actually. Actually about 2018 or 2017. And this was designed in the Hong Kong Polytechnic University. And obviously, Hoya got the patented the technology, and it's become the Hoya DIMS or MyoSmart lens, depending on whatever it's being called. But DIMS lens is basically has a single vision center. So you have the distance portion at the central part, which is about 9 mm in diameter. Now around it, you have small lenslets that have a plus power of plus 3.5 and a diameter of 1.03 mm. So basically you have a lens that in the central portion carries the distance prescription, and in the peripheral portion around that central portion, you have tiny lenslets that have a plus power of plus 3.5. Now, what this lenslets does is, remember the concept of peripheral hyperopic defocus. It gives you clear vision at the central portion, and because of the high plus power in the periphery of the lens or in the mid-periphery of the lens, it corrects that peripheral hyperopic defocus, which reduces the optical signaling axial elongation. Now, in a 2-year study, it was shown that the myopia progressed by about minus 0.4 diopters in individuals wearing defocus incorporated multiple segment lenses, compared to 0.85 diopters in the control group. And after 3 years, it was shown that the axial length decreased by about 0.5 compared to control. So you can see that obviously in terms of efficacy, this is better than the bifocal lens, where the those wearing bifocals progressed by about 1.25 diopters after 3 years, whereas we're seeing that this is about minus 0.41 diopter. In terms of efficacy, this would be about 50%, but as I've always said, pay attention to the values. And if you look at the axial length increase over a 2-year period, we're seeing that axial length increased by about 0.2 mm in the DIMS group compared to 0.55 mm in the single vision group. I'm not sure about I don't think DIMS is available in most parts of Africa, probably in South Africa, but not in Nigeria, at least where I practice. There is the HALT technology. Now, this is from Essilor. HALT stands for the highly spherical lensless technology. Now, HALT lenses has a similar theory, let's put it that way, a similar mechanism of action, just like the DIMS lens. However, it's slightly different. Now, it does have a central 9 mm clear zone, but you have an array of lenses that changes the focal point at the periphery of the retina, sort of a way to confuse the periphery of the retina. I have a cross-sectional image here that shows you what it is. So centrally here, you have your central clear 9 mm zone, which gives you the clear vision. However, in the periphery of the retina, what the lens does is it creates this 3D volumetric defocus in the periphery of the retina that stimulates, corrects the peripheral hyperopic defocus, but also will ensure that you're not getting the same sort of focus or array of rays in the periphery of the retina as you're getting in the central part of the retina. Essilor describes this as a volume of myopia defocus. So basically inducing myopia in the periphery of the retina by altering the rays of light going to the periphery of the retina. The lens looks clear when you look at it up close, but when you tilt it, you would see an array of 11 rings, basically, that are aspheric plus dots around it, and induces that volume of myopia defocus that brings about the myopia correction. Now, if you look at the 2-year data, we see that in the single vision group, myopia progressed by about almost minus 1.5 diopters. And in the HALT group, or in the Stellest group, let's call it the name of what the company calls it. In the Stellest group, it progressed by about minus 0.66 diopters, so about half of it. But with any most spectacle options for myopia control, as you go from the first year of efficacy to the second year, third year, fourth year, the efficacy sort of starts to plateau. And we see that after about 6 years, this was data published that was released by Essilor in March of this year, and was also presented at the AVO conference that was recently concluded last month. Oh, sorry, early this month. We see that the myopia progression over a 6-year period was decreased by about almost 2 diopters when Stellest was used, and axial length control about 0.81 millimeters. This approximates to somewhere around between 50 to 60% myopia control. But as I usually will say, look at the numbers, don't get carried away by looking at percentages. Now, the Stellest lens is available in South Africa for sure. Not yet available in Nigeria, but we're hoping it will be soon enough. As with other parts of Africa, it's not yet available. But if, as practitioners, we understand the role of these devices in myopia management, and there is an increased demand of these devices, obviously, these options will become more available to us African practitioners. not just for use for management clinically, but also for research purposes so that we look at efficacy and compare to other ethnicities and see what applies to us or what works for us. Now, there is the Myocare. This is from Zeiss. So the CARE stands for cylindrical refractive elements. Now, basically, this lens, in a way, is similar to the DIMS lens, but there is a slight variation. So instead of having like a spherical +1 that you would have, this is sort of individual cylinders that are put on the periphery of the lens. Personally, I have used this lens because it's available in Nigeria. I've used it for a year plus now, and it's quite good. I'm not advertising for the company or anything, but I can speak from my personal experience. And I mean, if you would like to incorporate this into your clinical practice, you can shoot me an email and I can link you up with the company and guide you and get things going. Um, Now, for the Myocare lens, you have a central portion of the lens that gives clear vision, just like the DIMS or the Stellest lens will do. However, this lens has two variations. There is the Myocare and there's the Myocare S. Basically, for the Myocare S, the clear zone where you have the single vision power is slightly larger compared to the Myocare. So typically, the Myocare S will be used for individuals, children older than 10 years of age. And Myocare will be used for those less than 10 years of age. The reason is the smaller the clear zone where you put your single vision power, you have more space for the cylindrical annular refractive elements that gives the myopia control. Now, this would give more aggressive myopia control in a younger individual because we know that myopia progression tends to be more rapid in younger children compared to older children. The plus power that the CARE elements or the small lenslets in the periphery actually induces is between plus 3.8 when you're looking at the Myocare S to about plus 4.6 diopters when you're looking at the full Myocare. And in the studies that have been published, what it shows is that if we look at the single vision group, this is 1 year data actually. Single vision group, the myopia progressed by about 0.41 diopters. Meanwhile, in the Myocare group, progressed by about 0.2 diopters, half of it. In terms of axial length increased by about 0.23 in the single vision group, but in the Myocare group, about 0.09, which is very good. So it gives very good axial length control. But what you always want to look at is look at 1 year data, look at 3 years data, and then make your conclusions. But the company has very good agents that are willing to work with you and guide you through the process, and I'd give them credit for that. Now, note that all the three technologies I've talked about, the Myocare, the HALT, the DIMS lenses, bifocal lenses as well. Now, these lens options, they actually give what's it called? Say they're actually based on the idea or the theory that we're trying to correct peripheral hyperopic defocus. However, they are not actually looking at other areas or other possibilities or other theories that could be contributing to axial length growth of the eyes. Now, that's where the dot lens differs from other options. Now, the dot lens actually works based on a signal or the theory of the on and off retinal signaling that controls axial elongation. And we know that the L and M cones plays a role in axial length increase and emmetropization through the bipolar cells, which will send signals and cause the axial length to increase or axial length to stop increasing, depending on what signal is being shown. Now, in these studies, it's been shown that when the off signals are triggered, basically by changing the contrast on the retina, you would be able to slow down axial length increase. And by the on signals that stimulates the L and M cones, you can actually trigger axial length increase. So what this lens does is, or what the technology does is, you have a clear central 5mm zone, which will give clear vision to the individual. And then in the periphery, what you have is sort of some distortions on the periphery of the lens or the mid-periphery of the lens that causes light scatter that changes the contrast in the periphery of the retina. Now, what this does is it would alter the L and M cone contrast and turn off that axial length growth elongation through the off pathway of the L and M cone and on and off signaling in the periphery of the retina. Now, this is the only spectacle option for myopia management currently that actually will not induce or it does not work based on the peripheral hyperopic diffuse theory compared to the others. And if we look at studies, this was the 1-year report. We're still hoping to get 3 years data for this lens. From the 1-year data, axial length was controlled by about 0.15 mm compared to control, and myopia progression was less by about minus 0.4 diopters, approximately minus 0.50 compared to control. Now, in all these options that we've talked about, you need to realize that binocular vision is also an important parameter, also an important factor that you should consider. Now, low lag of accommodation and low lag of accommodation and near exophoria, as I've mentioned before, would reduce the efficacy of your typical bifocals or your typical progressive addition lenses. But for this class of patients, you would need to incorporate prisms into that. But beyond just whether the myopia control strategy that you have put in place will be efficacious or not, looking at the binocular vision can also determine risk of progression. We've also seen data that shows that children who have a high lag of accommodation and children who have near isophoria and myopia tend to progress faster than those who don't. So the idea of the interplay between myopia progression, binocular vision, and accommodation, you can't actually separate them. They actually work hand in hand, and it's something that you have to understand. And it's okay if it feels complicated. You can actually co-manage these patients, like I said, with a vision therapist and orthoptist to get the best out of everything. Also, you need to understand that contact lens options can also impact the binocular vision in myopia management, but we won't talk about that today. We're going to talk about that when we're talking about the contact lens options for myopia management. We'll focus on the spectacle options of things. Now, for the specific myopia defocus spectacle lens options that I've listed before, what does research say about how they impact binocular vision? We know for the highly spherical lensless technology, that's the Stellest lens, it doesn't really cause any significant impact on binocular vision or accommodative response. Similar for the DIMS lens, in their 2-year study, they actually looked more at the accommodative side of things, and there was no impact on the accommodative response in these individuals. But there are certain things that I would say I would give from my clinical experience from managing myopia with these lens options. You need to discuss the parameters of the child's eye with the parents. Present what is normal. If you are speaking to a parent and you say your child has a -4 myopia, and the axial length is 25.5 millimeters, those things don't make sense to the parent. Something like the normal eye, I mean, we're done with your child examination, and these are the findings. The normal axial length will be about 23.5 approximately. And your child, I'm concerned that your child's axial length is longer than what is normal. And the longer the axial length, there are certain risk factors associated with it, like glaucoma and cataract. You do not want to go with scare tactics of saying the child axial length is 25 or is 26. If you don't do anything, they will become blind from myopia, blah, blah, blah. That would just scare the person away. Focus on the facts and don't overplay or overflog things. Create a risk profile for the child so that you know if your axial length is this is what you're likely going to use. If you're at high risk of progression, for example, you look at the myopia control strategies that have stronger efficacy. If you're at low risk of progression, use options that maybe have moderate control. You also would obviously need to look at the financial implications of what the parents can afford, but that should not form the primary goal for what you're doing. Yes, a lot of these myopia control interventions are not cheap, and considering that we're in a low resource setting in Africa, cost is always something that's going to come up at the end of the day. But do what's best for the patient and do the best that you can do. At the lower end of things, like I've said, even though bifocals and progressives are at the lowest end of the spectrum in terms of myopia management, it's still better than just giving single vision spectacles or single vision contact lenses. And it's important that you get the parents on board with the strategy that you've put in. Do not overpromise that you're going to completely stop myopia from progressing. Your goal is to reduce the rate at which it's progression, and over time you can stop it. But yes, in some cases, clinically, we do see that there is no progression, especially with the contact lens options. But if you have been able to slow somebody who was progressing at a rate of 1 diopter per year, and you've been able to slow that to 0.5 diopters or 0.25 diopters per year, that's still good clinical success. Again, there is this fear when it comes to prescribing bifocals or progressives or multifocal contact lenses or some of these might be a difficult spectacle options to kids because you're worried, oh, adults give you headaches when it comes to bifocals or progressive addition lenses. Kids are very forgiving. They mostly don't even notice what you're doing with the addition portion. So long as they can see clearly, they're mostly good. Schedule appointments for myopia management so that you don't get overwhelmed, and make your practice kid-friendly so that children enjoy the experience. Something I always tell people who I teach myopia management to, who come to our practice to learn, is you want to be the hero at the end of the day. Don't be the same, don't be the doctor who's going to do the refraction and everything and get the patient to do Exhalent and be the same person who's going to put the eye drops. Kids tend to be a little bit withdrawn after you've put the eye drops in their eyes. Let somebody else put the eye drops, maybe an intern, maybe an admin staff or a non-clinical staff, but let somebody teach them how to do it, obviously, but let somebody else do the eye drop. And you'll be the hero and come in and say, oh, this auntie put the eye drop for you. I'm sorry, let me take a look. And then you can examine. The children are more receptive that way. And it's important that you're measuring PDs. Obviously, you'd have measured refraction, your cycloplegic refraction. Frame measurements are very important, and the fitting height is very important when you're doing myopia management. Now, one important question that was asked yesterday or the day before was, when do you start myopia management? As soon as you diagnose it in a child, you want to start. But what's more important is the confusion about when to stop. You might see a 17-year-old who maybe is a -3, and you're wondering, is this child still going to progress or not? So there was the correction of myopia evaluation trial study that had looked at a very wide variety of patients over a wide variety of age groups to see when myopia stabilized. And what that study showed was 48% of myopes had stabilized by 77% of myopes had stabilized.
Yeah.
Just mute this person. All right. 77% of myopes had stabilized by the age of 18. 90% of myopes had stabilized by the age of 21. And 96% had stabilized by the age of 24. Now, it's easy to say, oh, by the age of 18, yes, most of them have stabilized, but let's flip these percentages and see how that may apply to you. If you have a 15-year-old sitting in front of you and you're asking yourself, will this child still progress? 52% of children are still progressing by the age of 15. 23% are still progressing by the age of 18. 10% are still progressing by the age of 21. So what that means is after the age of 18, you may want to start slowing things down. By the age of 24, only about 4% of myopes are still progressing. So Is adult myopia progression a thing? Yes, it is a thing. Myopia can still progress in adults, but in very few adults compared to younger individuals. Thank you all for listening. You can leave your questions or comments in the chat section and I will take them. All right, so I see some questions already. But if you have more questions, comments, please go ahead and keep them coming. So the first question says, most of patients get difficult with um, difficult in adapting to PALS. How do you manage this, especially in children? Well, again, personally, maybe I'm just blessed, but I don't have these issues with children. It's not like maybe one or two haven't complained, but there are very few children who have actually complained about maybe the floor looking like it's coming up, or maybe the distortion that they notice when they look to the sides of progressive addition lenses. Most of them would not give you this headache. But for the few who give the headache, just counsel. Most times, I actually find that, again, in my practice, because bifocals or progressives are the lower end of the spectrum, I always give bifocals or progressive addition lenses in addition with low dose atropine, except I am doing it for somebody who has clear-cut benefits, like the study that I showed that if the individual has a near isophoria or high lag of accommodation, I will give a bifocal or progressive straight without even maybe a combination. If the individual has a low lag or near exo, that's when you might be thinking of prismatic bifocals. But even those might be difficult to come by depending on the labs available to you. So most times I would end up doing a combination of low dose atropine together with the progressive addition lenses for myopia management for those kids. But I haven't found that it's been an issue for the kids that I manage. But if that presents as an issue for the kids that you're prescribing progressive addition lenses to, simple thing is to counsel them, and most of these kids will adapt. Kids are very forgiving. The next question is, bifocals are more effective than progressives by about 30%, even though the efficacy is much better with patients who have high ISO. Yes, I already mentioned this. Some parents who cannot afford other options will prefer progressives because the line doesn't show. Well, for kids, your primary concern shouldn't be cosmesis, and this is something that you need to actually discuss with parents. You need to actually discuss this with the parents and mention, because for bifocals, the near zone is larger than what you get with a progressive addition lens. So obviously you get better peripheral hyperopic defocus control and a larger area that controls the lag of accommodation. This other comment says, in a patient where there is no lag or ISO, how do you determine the add? So in a patient where, I mean, it's hard for you to say that there's, for you to see a patient who doesn't have an accommodative response. I mean, I don't know if that's even possible. There would always either be a lead or a lag. The question is, if that lag, for example, falls in the normal range, maybe plus 0.25, plus 0.5, plus 0.75, because we'll consider plus 1 above high lag. But if that lag falls around the normal range, which is very low, maybe plus 0.5, you can't say that you're going to remove the 0.5 and get an add. What we would typically just advise is give the add that has been studied in most randomized clinical trials that has used bifocals or progressive addition lenses. So you'll be given an add of +2. But also you need to also look at the binocular vision of the individual. Obviously, individuals who have near ISO will benefit from an add because it reduces the near ISO deviation. Individuals with a high lag will benefit more. But for those who have low lag or of accommodation or normal lag of accommodation, you should be looking at either incorporating a prismatic bifocal into it or give it in addition with low dose atropine to get better myopia control efficacy. The next question is, can these spectacles, DIMS, Holtz, MyoCare, be recommended for myopic patients above the age of 21? Yes. There are few studies that have actually explored adult myopia progression. We're actually trying to collect data for that, but as somebody who practices myopia management, I can tell you for a fact that myopia progression in adults is a thing. It's not common, but it can happen. So you need to keep this in mind and realize that just because this is an adult's eye, and the atrial length is still increasing, and the strategy was meant for or was studied in kids, does not mean it may not work for adults. We would not know if we don't try. Personally, I have prescribed the MyoCare to a couple of adults with so far good efficacy. But what studies have shown, or randomized control trials have shown or studied more, is the use of center distance multifocal contact lenses for myopia management, which we'll talk about in the following days. But yes, if you look at the COMET study, about 4% of adults are still progressing after the age of 24. So it doesn't mean that you can't do myopia control in those adults. But also, something we need to remember is while we keep talking about giving DIMS or MyoCare or Stellest or what have you, you need to also remember environmental modifications. Less screen time, more time outdoors, the range at which children are reading, 20/20 rules, teaching visual hygiene. Incorporate your myopia management strategy with an environmental modification so you're getting a holistic management and not just one-sided. The next question says, prismatic bifocals mostly come in executive bifocals. What do you do when a patient rejects this for the child for cosmetic reasons? First of all, if you know where we can find executive bifocals, please give me a heads up. It's very difficult to find executive bifocals these days. But yes, the D-top bifocals or your fused bifocals and what have you, some parents do have that concern. And typically, my first counsel to the parents is, we're not trying to do this for cosmesis. I lay out the benefits of myopia control, explain the idea of what we're trying to do. However, if this is still a concern, I could try an invisible bifocal or progressive addition lenses. But if I am going to be switching from something, because again, executive bifocals gives better myopia control than the fused bifocal or the progressive addition lens, simply because you have a large area of plus power that would take care of superior peripheral hyperopic defocus and also the lag of accommodation. But they're difficult to find. But if the parents are concerned about that, I would then add something to the progressive addition lens that I'm going to prescribe so that the line doesn't show. Most times that would be atropine to control that. Someone's asking, how do we get low dose atropine? Check around your area for a compounding pharmacist. Typically, you might want to go to maybe a teaching hospital, reach out to their pharmacy department, and if they have a compounding pharmacist, they can actually compound low dose atropine for you. There is commercially available 0.01% atropine, but I do not use 0.01% atropine. I use 0.05. Clinical studies, and even initially when 0.01 came out, I was using 0.01, but I've still seen initially the first 1 year, it seems to control myopia. And after the first 1 year, it's almost as if they're just putting saline in the eyes until the studies came out to prove what I was already thinking. And what the studies have shown is that by after a year, the efficacy for 0.01% actually goes down. But in terms of side effects, it is less with 0.01. The higher the concentration of atropine you use, the more side effects you're likely going to see. What the studies, the ATOM study, there was the ATOM 1, ATOM 2, and the ATOM 3 study that looked at the effect of suddenly stopping low dose atropine. But what the ATOM studies have proved to us or shown to us is the 0.05% is more efficacious, and then don't stop it suddenly. Taper down. So you could go from 0.05 to 0.025 to 0.01%. However, if you're using atropine as an adjunct therapy to something, bifocals, progressive addition lenses, or even contact lens options, ortho-K or center distance multifocal contact lenses. Yes, you can consider using the 0.01%, but always ensure that you keep certain things in mind. From the ATOM studies, we know that low dose atropine would reduce amplitude of accommodation by about 1 to 2 diopters. We also know that low dose atropine will cause about 1 mm or 1 to 2 mm increase in pupil size. And we know that it also may cause redness for some kids and itching for some kids. I don't see the redness in my practice, even though I use 0.05. I don't see the redness. Most times, patients don't complain about the blur near vision because in my practice, it's a rule. If I'm going to give you low dose atropine, it's definitely going to go with a photochromic spectacle that's either bifocal or progressive, and that's it. So by giving the bifocal or progressive, I would give an add of +2. That takes care of the slight decrease in the amplitude of accommodation, so the kids don't even complain about near vision being blurred. They don't even notice that anything is happening. And secondly, because it's transition, when they step outdoors, it turns a bit dark to reduce the glare that they may experience. The only thing that you may experience, which I see, and in a small fraction of patients, is the allergic conjunctivitis that goes with prolonged or long-term use of low-dose atropine. But I find that giving your antihistamines or mast cell stabilizers does take care of this beautifully for most of the patients. I think I've answered all the questions, but if you have any other questions, please keep them coming. The recordings for each day's session will be available on the iAfrica Media YouTube page, so you can go back and rewatch them. If you have questions, you want to reach out to me, my email's here. You can always reach out to me. I'll be happy to answer your questions. If you're interested in participating in research, I'm happy to, we don't have any space in my lab right now, but I'll be happy to link you up with the Cephi team. I'm not the only person researching on myopia in Africa. There are others as well, and we can fix you up somewhere. But yeah, if you have any questions, shoot them my way. I'll be happy to answer them. Also, for the contact lens options, we'll be discussing that in a couple of very soon. And also, as I said, BioLens this week will be announcing training options available to African eye care practitioners to incorporate center distance multifocal contact lenses and orthokeratology into your practice. And there'll be certification training for those who meet the criteria and who are interested in orthokeratology fitting. So thank you all for listening. Thank you all for joining in. I think that brings us to the end of today's lecture. I'll stop sharing my screen now.